Good morning and welcome. We're live from the Kansas City area today on a lovely day. I am Kim Nitz, Associate Director of Community Programs for the Parkinson's Foundation. We're passionate about helping each and every person with Parkinson's to live better, so it's wonderful to be reaching so many of you today. We do have hundreds of participants from all over Kansas and Missouri, as well as the whole Heartland and beyond. So we welcome you all. We know that the KU Symposium is always an important event for the Parkinson's community, so we're thrilled today to be partnering with KU to bring it to you in our virtual meeting format. A reminder that attendees will be muted and off camera during today's presentation to help reduce background noise, so just make yourselves comfortable, and also know that we will be sharing a link to today's program recording in the week ahead. So keep an eye out for your email for that. Today's program will offer important information about Parkinson's disease from Parkinson's experts at KU. We have built-in time to take your questions, so please submit those at any time via the Q&A icon at the bottom of your screen. And please do try to keep those to a general nature related to today's topic. So at the Parkinson's Foundation, we're a national organization working to support the estimated 1 million Americans living with Parkinson's disease, as well as the many who care for them and those working to end the disease. We focus on 3 goals: advancing PD research, improving care for those living with Parkinson's, and empowering the Parkinson's community with educational resources. These resources are extensive and include our website, parkinson.org, our free educational book series that you can download or order in hard copy, as you see here, a library of recorded podcasts and webinars. We have care partner education and resources, and our hospital safety kit called the Aware and Care Kit. We also offer a free national helpline at 1-800-4PD-INFO, which is staffed by Parkinson's specialists ready to assist. We are very proud of our 47 centers of excellence, those medical centers setting the highest standards of care for people with Parkinson's, including at the University of Kansas Medical Center, led by Dr. Pahwa and his team, who will be presenting today. We're also pleased to offer PD Generation, a national research initiative that provides genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost in English and Spanish. The goal of PD Gene is to use genetics as a powerful tool to help uncover what is responsible for slowing or stopping the progression of Parkinson's. You can learn more at parkinson.org/PDGeneration. We currently have over 2,000 participants involved in this study and are proud to recognize that KU continues to be one of the top 3 sites in the country for PD Generation participation. We'll be sharing information via our email following the program for further details. We have started a new initiative meant to capture the Parkinson's community's voice on various topics around Parkinson's, like mental health, telehealth, cannabis use, and others. Participants will be contacted up to 4 times a year requesting that you complete a 10 to 20-minute survey, and we'll always share those findings back with the community. You can visit the link on your screen for more details. And while we're ready to get started, I'd first like to thank the sponsors of today's program, our gold sponsors, Boston Scientific and Synovian, as well as our silver sponsors, AbbVie, Acadia, Adamas, Amneal, Medtronic, Neurocrene, Kyowa Kirin, and Accorda. We truly appreciate their support, which helps keep today's program and many others free and available to our Parkinson's community. You'll find educational materials about these companies by visiting our chapter supporters page located at the link you see on your screen and in the chat. And now I have the pleasure of introducing our first speaker, Dr. Kelvin Au. Dr. Au recently joined the Movement Disorders Division of Neurology at the University of Kansas Medical Center just this month in August of 2021. He graduated from the University of Manitoba Faculty of Medicine in Winnipeg, Manitoba, Canada, and completed his neurology residency at the University of Calgary in Calgary, Alberta, Canada. He has now completed a 2-year movement disorders fellowship at the University of Florida in Gainesville under Dr. Michael Oken and Dr. Christopher Hess. Dr. Au is certified by the Royal College of Physicians and Surgeons of Canada in neurology. His interests include clinical trials for various movement disorders, deep brain stimulation, and botulinum toxin therapy for various forms of dystonia. He has published articles relating to DBS and movement disorders and has a research interest in multidisciplinary care for Parkinson's disease. Dr. Au is dedicated to improving care for Parkinson's patients and is happy to be joining the team at KUMC. So I'll now turn it over to you, Dr. Au, to share your slides.
Well, thank you very much, Kim, for the kind introduction. And thank you, Dr. Pahwa and Dr. Lyons and the Parkinson's Foundation for the opportunity to speak today. Yeah, I'm Dr. Kelvin Au, and I'm going to be talking today a bit of an update on Parkinson's disease and on the diagnosis and the treatment of the motor symptoms. I have nothing to disclose for today's presentation. So we're here today to talk about Parkinson's disease, which is increasing. Kim mentioned that, a million Americans, an estimated of 1 million Americans have Parkinson's disease. This is a figure looking at kind of the global burden. In 2015, there are about 6 million people, and it's only increasing. By 2040, it's projected to increase exponentially. And some people might even term call this a pandemic. Some people are calling it that. It's something that we're very familiar with, this term. But what is a pandemic? It's something that's increasing worldwide without any borders. And we see that Parkinson's, for a variety of reasons, is increasing in that way. And we're here at KUMC, as well as the Parkinson's Foundation, to help give education, to help people that are impacted by this condition. The classical motor symptoms, many of you are familiar with this. When we teach medical students, we give them this acronym: tremor, rigidity, akinesia, and postural instability, or TRAP. The tremor is commonly a resting tremor. Rigidity, people have stiffness in their muscles they feel. Akinesia is a medical term for a paucity of movements, or it's also related to bradykinesia, which you'll hear, or just slowness of movements, slowness with initiation of movements for different tasks with fine motor movements. And then you get something called postural instability, where you have difficulties with your balance. The first people described with Parkinson's disease were in the 1800s, and this is kind of the classical figure that some people depict, where you have an individual, their walking is a little bit stooped in their posture. They have short shuffling steps. They have the tremor. And that's, the image that we've had for a long time. But, that's changing as we get to know more about Parkinson's disease. Parkinson's disease, how we make the diagnosis is together with your physician, and it's called, what we call a clinical diagnosis. It's still based on the history of symptoms, as well as the examination of those motor symptoms that I mentioned before. That is how we together make the diagnosis, although we do have some different tests that we can use to kind of help correlate with the physical exam and the history, to help kind of give us a better hint of what's going on. If there are sometimes when you might be very early on in the stages of Parkinson's disease where the symptoms are there, don't quite meet the threshold for the clinical diagnosis, but we turn to these types of scans and different tests that might help us, say that swing one way or the other. Is this Parkinson's disease or some other related condition? One of these are called a dopamine transporter, or SPECT scans. They're called a DAT SPECT scan. This looks at the dopamine transporter in the brain, and it's a nuclear medicine scan that kind of help us differentiate things like between Parkinson's disease, where it'll be abnormal, or other conditions that are often confused with Parkinson's disease, like essential tremor. Often, I put down often not needed, because really, again, as I mentioned, it's a clinical diagnosis. If we see you over time, Parkinson's is a neurodegenerative condition. You'll develop likely more symptoms over time, and that often seeing you, every 6 months can kind of give a sense of, is this Parkinson's disease or not? People often ask about the MRI of the brain. That can help differentiate Parkinson's disease from other conditions, other things in the brain that can cause the symptoms of Parkinson's disease. So sometimes that is done, but often in Parkinson's disease that is normal. And then there's this increasing talk about biomarkers. A skin biopsy and different smell tests are increasingly being used to help with the diagnosis of Parkinson's disease. This is the DAT scan that I mentioned before. It's a nuclear medicine scan, as mentioned. This is an example. We give you a radio tracer looking at the dopamine transporter. It lights up in the brain. This is the image of the brain. Often we get what's kind of looks like a comma shaped expression of the dopamine transporter. That's normal, but in Parkinson's disease, that's reduced. You can see how this is, this looks more like a period than a comma. It's reduced in this area. So that's something that kind of helps us with the diagnosis in select cases. As I mentioned, every person with Parkinson's is unique. There are no two individuals with Parkinson's that are exactly the same. There's differences in how the symptoms progress, what symptoms are most prominent, and how fast the symptoms will progress. I showed you that image earlier of the individual with the stooped posture, an older gentleman, but we know that Parkinson's affects everybody differently. You can have a mild form of Parkinson's, and this is an individual where she's early on in the condition, and she's actually quite active, but she might have a little bit of inturning of the foot, something called dystonia, and that's that's all the symptoms that she has that she's able to manage. You can have intermediate Parkinson's disease where, when you're on medications, and we'll talk a little bit more about this, you get some on time, but then when the medications wear off, you have some off time. And they're quite different looking depending on the time of the day and relative to the medications that they're taking. And in some individuals, Parkinson's disease can progress quite fast. And within several years, they're needing a mobility aid, a walker in this case. But it really depends on, it's very different for each person. So working together with your physician along the course throughout the stages would be very important. The progression of Parkinson's disease, here is at time point 0 when you're diagnosed with Parkinson's disease. Dr. Sharma shortly will talk about some of the non-motor symptoms that can occur before, the diagnosis comes about. But we know that, the time span here, 0, 10 to 20 years, this looks very different for different people. And there's many different symptoms. I talked about the bradykinesia, rigidity, and tremor, but there's other issues, freezing of gait, falls. That may come later, but again, that occurs at different time points for each individual. In the bio, I mentioned, Kim mentioned that multidisciplinary care is something that is very important, and I think is very important for every person with Parkinson's disease. You of course have the patient, the caregivers, very important part of the team, but we work very closely with speech therapists, physical therapists, occupational therapists, neurosurgeons, if needed, social workers, patient foundations. It really is a team-based approach because Parkinson's is not just the tremor. There's many other issues that can occur in Parkinson's disease that warrant all these different specialists with their expertise helping, including the neurologist, of course, and your primary care provider helping navigate and direct all the other specialties combined. So we're talking about, in terms of treatment, physical activity is very important. Exercise has been shown to be very helpful in Parkinson's disease and helping prevent some of the deconditioning. It's helpful in other aspects of Parkinson's, including some of the mood symptoms that might happen. Things like yoga, many of you are involved in rock steady boxing or even dance. Even just walking would be very helpful for Parkinson's disease, and we just highly recommend that. If you're in a state where you're wondering, is it safe to exercise? We can work with you and refer you to both physical therapy and occupational therapy, and they can look at you as an individual and see what kind of plan might be appropriate for you in terms of exercise that would be safe to do so. Because I know many people often have difficulties with balance and the postural instability, high risk for falls, but there are many options for exercise that can be done safely, even though they may have those problems. So we're going to go through a little bit of some of the treatments, including medications for Parkinson's disease. I know some of the questions that we often get are, well, how do I know that I need to start medication? Or when do I start medications? Do I need medications? These are very good questions. We get them often in the clinic, and we often throw them back at you and kind of ask, ask these questions to ask yourself, whether or not you need medications. Well, are the symptoms bothersome? Are they bothering you to the point where it's impacting your daily function? Is the tremor interfering with daily activities? Is it causing social embarrassment? That's a very important and often overlooked aspect of the symptoms of Parkinson's disease. How is the slowness and stiffness affecting you on certain tasks? And then ultimately, it's about quality of life. Are you finding it more difficult to do the things that you enjoy? If these questions, if they resonate with you and they are causing you some issues, then that's kind of when you want to consider treating these symptoms, because we have many treatments available that can help with the symptoms of Parkinson's disease and to improve your quality of life. So the first one is Carbidopa, Levodopa. This is something that's been around for over 5 decades. You'll hear the term perhaps gold standard. It is the gold standard treatment. It's often the most often prescribed medication for Parkinson's disease. In Parkinson's disease, dopamine is deficient in the brain, and it makes sense to replace it. The 2 parts of Carbidopa, Levodopa, there's 2 medications in this combination. The Carbidopa helps prevent the breakdown of the other drug, the Levodopa, helps minimize some of the side effects, including nausea and GI upset. And it's the Levodopa that eventually goes into the brain and it's converted to dopamine to help with your symptoms. There's many different types and formulations. Most commonly, we use the immediate release, the brand name Sinemet. The Carbidopa, Levodopa immediate release, is fairly short acting. It gets into your system within 30 to 60 minutes. There is a controlled release formulation that is a little bit longer acting, although its release can be a little bit less predictable than the immediate release. There is an oral disintegrating tablet that you can use for those that may have some, we use that in particular situations, perhaps when there's some swallowing difficulties. You may have heard of this extended release capsules called Rytari, where the medication's infused in certain beads, and those beads release the medication at different time points so that you may get a smoother on or off time. There's a combination pill with another medication called entacapone, called Stalevo, that helps extend the effects of the Levodopa. We have Carbidopa, Levodopa in an intestinal gel that we inject directly into the intestine that is used in select patients that can help give a constant delivery of these medications to help you have your motor symptoms under control. And more recently, there is a new Levodopa inhalation powder. It's an inhaler that you use up to 5 times a day. It's for when you just need it, when you have an off period. It's not meant to replace the Carbidopa, Levodopa medications that you're taking, but just if you're having an off period and you just need to have a fast-acting rescue therapy or on-demand therapy as needed, that's something you can use as an inhaler. Though you want to avoid that if you have certain lung conditions, asthma, COPD. Its side effects include the same side effects as the Carbidopa, Levodopa, and then sometimes you can get a cough, some nausea, or it can also change the color of your sputum as well. I won't go through all those different formulations, but just going to talk briefly about the most commonly used medication and form of Carbidopa, Levodopa, the immediate release. As mentioned, it's fairly predictable in its response in that by 30 to 60 minutes in most people, it will have its effect and it'll last several hours, 2 to 3 hours after that. It'll help with the symptoms, the motor symptoms, including the slowness and stiffness. Tremor, it can be variable with the response. Some people have a good response with this with tremor, but not always. And in terms of the walking, again, I put variable response. It may not help with some of the balance issues per se, but if it helps with some of the stiffness, it may help with your walking speed, as well as if you're having the stiffness and that's impairing your walking, that it might help with your walking in that standpoint too. So that's why it's a variable response there. The side effects often, and when you're first starting the carbidopa, levodopa, you can get a little bit of GI upset, you get a little bit of nausea. Often that goes away as your body gets used to it. It can lower your blood pressure, so it's important to keep a note on that if you're feeling lightheaded or dizzy when you stand up too quickly. You can get some hallucinations with higher dosages. You may have heard of this term called dyskinesias, which are abnormal wiggly movements, is what we say. These extra movements, kind of writhing movements. That happens over time, and it's important to know that that's a result of the progression of Parkinson's disease in combination with the levodopa, and not specifically just caused by the levodopa. It's the Parkinson's plus the levodopa that as you get into the more advanced stages of Parkinson's disease that lead to that. And as a result of how fast carbidopa levodopa acts, you may require frequent dosing. Often we start at 3 times a day, but you can, there's people taking it 5, even 6 times a day every 3 hours, 2 to 3 hours even. Another class of commonly used medications in Parkinson's is dopamine agonists. These are work quite similarly to the carbidopa levodopa, but just with a different mechanism. It mimics the acts of dopamine, helpful for the motor symptoms. There's a few listed here: pramipexole and ropinirole. Those are in different pill forms. There's some extended release formulations of that. There's also a patch. It's called a Nupro patch that can also be used to help cover some of the symptoms over a 24-hour period. These medications can also help with restless leg syndrome. If you're using these medications on their own without the carbidopa levodopa, sometimes the dyskinesias are less common. There are some other medications that you can use in this class called apomorphine. There's an injectable as well as a sublingual film, something that you put under your tongue that you would use for those kind of sudden off periods or periods when you just need a quick pick me up in terms of the medications until the other medications that you're taking can kick in. Again, as I mentioned, on demand, just when needed. And if you find that you're using these injections or the film or the inhaler, the on-demand therapies quite commonly, then we would have a discussion with you and see if we need to raise some of your other medications that are working in the background. They're okay to be used, once or twice a day, a few times a day, but if you're using them a lot, then yeah, we'll increase your other medications, or we would consider that. Side effects for these can be common, especially as you get older. Sleepiness, somnolence. You can get these sleep attacks where you just, have difficulties fighting off the urge to sleep. They can lower your blood pressure as well. You can get some visual hallucinations, seeing things that other people don't see. Impulsivity can occur. Things like extra spending of money, gambling, hypersexuality, binge eating, kind of behaving not like yourself can happen while you're on these medications, particularly at higher dosages. And then you can get some leg swelling with these medications too. So it's important to monitor for these, and we'll ask you to at each visit when you're on these medications. Another class is the monoamine oxidase-B inhibitors, or MAO-B inhibitors. These aren't as potent as the dopamine agonists or the carbidopa levodopa, but they can be used. Sometimes they're used in monotherapy just by themselves in earlier stages of Parkinson's disease, or sometimes they're added on top of the carbidopa levodopa or the dopamine agonist. These are rasagiline, selegiline. Rasagiline is a once-a-day dosing medication, and selegiline is twice a day. These are typically well tolerated without significant side effects. You might get some lightheadedness or mild GI upset, but you can discuss with your doctor about whether this is good for you or not. As you progress with Parkinson's, you can get some difficulties, or what we call complications, with carbidopa levodopa. You can get some wearing off where it doesn't last that 4 to 5 hours as typically described. You can get it delayed on if you take the medication, but it doesn't kick in until an hour or two later. Often that's related to some gastric emptying problems. Your stomach and colon isn't working as fast as it typically is, which is common in Parkinson's disease. You can get some what we call dose failures, where it just doesn't seem to kick in at all. Or you can get some random on and off where there's, you're taking the carbidopa, levodopa consistently, but the expected time frame of when the medications kick in isn't exactly correlated to that, which can be somewhat frustrating if you're trying to plan your day, you have activities and such. And the reason for that is that, Parkinson's, how you respond to the medication changes over time as the disease progresses. In the early stages, if you take the blue dots here, when you take your medications, this blue overlay is when you have good on time, your symptoms are well controlled, you take those medications, the medications gets in your system and then comes out, and you're constantly in that, what we call the therapeutic window. But as you progress in the disease, this therapeutic window gets shorter and shorter, and then you may end up getting to the point where at the peak of the carbidopa, levodopa in your system, you get those extra movements, those dyskinesias, the wiggly movements, before it comes down into the good on time. And then you may even get below the therapeutic window in that you have those wearing off episodes. So then it becomes a balance between having those extra movements, having too much of the medication to having too little of the medication, where you're off and you're slow and stiff and maybe having some freezing. And that's what we work with in clinic. We'll work with you to adjust the timing of your medications as one strategy for that, to help with the motor complications. And there's other things that we can do as well with other medications, which we'll talk about here. One of the strategies for that is adding a medication in the COMT inhibitor class. These are to be taken with levodopa, and how it works is it prevents the breakdown of levodopa, so it extends its effect. One of the most common ones used is entacapone, and that was in a combination pill that I mentioned earlier called Stalevo with the carbidopa, levodopa. They're meant to be taken together with levodopa. These won't work otherwise. And then there's recently a newer version called opicapone that's been recently approved. This tolcapone, we rarely use it because there's a potential for liver side effects, but these are something that you can discuss if you're having a lot of that wearing off time, although this can worsen some of the dyskinesias if you're having those. So it's a balance, and we would just kind of discuss and look at you individually to see if this is appropriate for you. Other approved therapies include this class of anticholinergics. They're some of the older medications used in Parkinson's disease before we had the dopamine agonists and the MAO-B inhibitors and COMT inhibitors. These are, you may have heard of them, benztropine or congentin or trihexyphenyl or artane. These can be used in very select cases for tremor control. If there's a lot of dystonia, that's involuntary muscle contraction and cramping that can happen in Parkinson's disease. But we typically use it in younger patients because there's the potential for side effects, including difficulties with cognition, memory, and thinking. And amantadine is another medication that we often use. It can help with some of the motor symptoms of Parkinson's disease, but often it's used to help with those dyskinesias, those extra movements. And recently there have been several other medications that have extended so there's regular release, but there's newer types that have extended release capsules. Gocovri actually is a medication approved, the only medication approved in Parkinson's for both off periods as well as the dyskinesias. So you can discuss again with your physician if that's right for you. Side effects include dry mouth, dry eyes, lightheadedness, constipation. It can worsen hallucinations, and you can develop a particular skin rash with the amantadine called livedo reticularis, but it's something that goes away once you stop the medication. And then in, I believe, 2019, there's a new medication called the istradefylline or Nurians that can help with wearing off. It's a once-a-day medication that you can take. It can worsen dyskinesias and hallucinations. So consider that if you're having some wearing off that we can add on to the other medications that you're taking. This isn't quite a medication per se, it is an injection. So botulinum toxin, there's brand names Botox, Xeomin, Dysport, and Myoblock. This is a toxin that we use in Parkinson's disease that can help with a variety of different symptoms. One of them including the dystonia, muscle cramping. Some people will have cramping in their calves, their toes are curling in, their ankles are inverting in. And what we can do is take this toxin and inject it into those affected muscles to help weaken the muscles. It's temporary, so I mean the side effects are weakness, but we'll work with you and do some injections starting at a low dose and get to the point where it helps with the symptoms without impairing your function. And it lasts about 12 weeks, so you need to have kind of repeated injections. If you have these side effects, they'll go away after 12 weeks. That's because your body clears it out, but it's something to consider. We can also use it if you're having a lot of what's called sialuria or excessive drooling. We can inject it into the salivary glands, and that can actually help prevent extra salivation as well as a strategy. There are some advanced therapies in Parkinson's disease and we typically reserve this when we've been working with you for several years, but the symptoms progress despite different medication strategies, trial of different combinations of the medications I mentioned or different timing and frequencies. And when we get to the point where you have those extra wiggly movements, those dyskinesias, those are bothering you and affecting your function, and we're not able to control those with the medications, or you're having a lot of those on and off periods pretty frequently. You're either on too much and having dyskinesias, or you're having a lot of wearing off. That's what we call motor fluctuations, where you're basically yo-yoing back and forth at very frequent intervals throughout the day as you're taking the medications. Or if you have a tremor that is refractory to medications and that it's not really adequately treated by the medications, that's when we consider some of these advanced therapies. And these include deep brain stimulation, focused ultrasound, and the Levodopa intestinal gel pump that I mentioned before. So deep brain stimulation, it is as it sounds. There's a picture here on the right where we work with our neurosurgery colleagues, and we implant an electrode in the brain, and we give electrical current and stimulation off of that electrode, and that helps interrupt some of the abnormal circuits that are seen in Parkinson's disease in the brain. And it can be helpful for the motor symptoms of Parkinson's, the slowness, the stiffness, and tremor, as well as help with those extra movements, the dyskinesias. It's not meant to replace the medications, but it will help with some of the things that over time, as your Parkinson's progress, the medications can't help with. As I mentioned before, the extra dyskinesias and the fluctuations of the Carbidopa, Levodopa, and the medications. And that is, there's an electrode in the brain, and there's a wire that extends down into your chest here for the battery. And we help give you different programming parameters and to help with the symptoms. Focused ultrasound is something that's used in Parkinson's disease. Often it's used in select cases where perhaps tremor might be a prominent symptom. And it creates a small lesion. How it works is it creates a small lesion in the brain using ultrasound waves, and they focus it in very tightly into one spot, and they target that, and that creates a small lesion in the brain or small hole in the brain to help target where there are abnormal cells in the brain causing the tremor and the symptoms of Parkinson's disease. Comparing the two with focused ultrasound, for right now, we're looking at just one side that you can only do focused ultrasound on. They're looking at perhaps giving you the ability to do both sides, but it's for if you have one side that has really bad tremor or other symptoms, you might want to consider this and discuss this with your physician. Your doctor should be able to kind of give you the pros and cons between deep brain stimulation and focused ultrasound in an individualized manner. And then the Levodopa intestinal gel pump, there's an extra surgery. It goes through the stomach, through the skin, through the stomach, and to deliver the medications at a constant rate in your intestine. So then you have you avoid the up and down that you get with taking the pills every couple of hours. And so some people can help, that can help some people. And that's depicted here. It goes into the stomach and it's connected to a pact where you would change it out every day or add the medication. And for some people, that's very good if they're not keen on brain surgery or focused ultrasound of the brain. So, I mean, these are quite advanced therapies. If you wanted to discuss them, we would have an entire team approach when discussing the advanced therapies and kind of seeing if you're a good candidate or not. As mentioned, it's the person with Parkinson's at the center, and really we are catering this type of therapy to you with neurology, neurosurgery, psychiatry, neuropsychology. We would have you evaluated and then to see which type of therapy is best for you. I think we're running short on time, but the take-home points is that treatment for Parkinson's disease, there's many options now. I mean, there is Carbidopa, Levodopa, which has been around for a long time. It is the gold standard, but there's many other options depending on what you're experiencing at what stage of Parkinson's you're at with whatever complications you may be. And management of Parkinson's involved a team of various specialties, as it's not just the motor symptoms, but there's many other things and aspects that play in Parkinson's. As you have Parkinson's and as it progresses, your medications will likely change over time. And as I mentioned, there's many treatment strategies. Just discuss with your doctor and keep an eye out for side effects, because if you're having a problem with one medication, you may be able to switch it out with another that might be helpful for you. Thank you very much.
Excellent. Thank you, Dr. Au, for all the great information. Next, we are pleased to introduce Dr. Vibhash Sharma. Dr. Sharma joined the Movement Disorder Division of Neurology at the University of Kansas Medical Center in August of 2016. He had completed a neurology residency at the University of Texas Southwestern Medical Center in Dallas. And following residency, he completed a 2-year fellowship in movement disorders and deep brain stimulation at Emory University in Atlanta. His second year of fellowship there was focused on DBS. Dr. Sharma is certified by the American Board of Psychiatry and Neurology. His research interests include DBS and various movement disorders, including Parkinson's disease, dystonia, and tremor. He is also interested in studying gait in different Parkinson's diseases, dystonia, and essential tremor. Dr. Sharma has published articles related to DBS and movement disorders, as well as presented several abstracts at both national and international meetings. And we now welcome you, Dr. Sharma.
Good morning, everyone. Thank you for the kind introduction, and I'm very happy to join the symposium. And this year, we were able to do it virtually. So I'm one of the faculty members at the Parkinson's Disease and Movement Disorder Centers at the University of Kansas. And today I'll be discussing about non-motor symptoms in Parkinson's disease. I have nothing to disclose. And just to make sure that everyone is able to hear me okay. Okay, so non-motor symptoms in Parkinson's disease are important aspect of the disease spectrum. Parkinson's disease is characterized by not only motor symptoms, which Dr. Au covered in the earlier talk, including tremors, slowness of activities, or shuffling gait, but they can also be associated with non-motor symptoms, including cognitive function or memory issues, and they can have psychosis. And these symptoms do not affect the movements. Non-motor symptoms can be present at all the stages of disease, and their frequency increases with disease duration and severity. Some of the non-motor symptoms can be present even before the onset of motor symptoms, what we call as prodromal Parkinson's disease. And with the disease progression, these non-motor symptoms can be bothersome, affecting their quality of life more than the motor symptoms. There are various non-motor symptoms associated with Parkinson's disease, including cognitive dysfunction and dementia, psychosis, mood disorders, pain and sensory disturbances, sleep disturbances, autonomic dysfunction, and fatigue. In the following slides, I'll be covering these non-motor symptoms. Cognitive dysfunction and dementia is common in Parkinson's disease. Early on in the disease, patients can have slow thinking, word finding difficulty, or tip of the tongue phenomenon where they know what they want to say, but they cannot come up with the right word. They can have difficulty with multitasking or planning things. They can develop impaired concentration or short-term memory issues. With the disease progression, these symptoms can become more prevalent, and it can, of course, like with aging, some patients ask us whether this can be a part of aging. It can be, but primarily it is due to the neurodegenerative process from the Parkinson's disease. Also, we have to remember that other factors can also contribute to cognitive dysfunction, including depression or anxiety or certain medications which they are on, including amantadine or anticholinergics or dopamine agonist. And Parkinson's disease patients can also have coexisting vascular dementia or Alzheimer's dementia. It is important to understand difference between mild cognitive impairment and PD dementia. Often in the clinics, we discuss about with the patients that you have mild cognitive impairment or this is progressing to dementia. So what are the differences? So with the mild cognitive impairment, there's gradual decline in cognitive abilities, which is reported by either a patient or family caregiver, or it can be observed by clinicians in the clinic. It can affect the single cognitive domain or multiple cognitive domain. For example, their memory or executive skills or attention can be affected. But the cognitive deficits are not sufficient to interfere with functional independence. So they are still functional, independent, doing all their activities without any assistance. With the disease progression, they can progress to PD dementia, in which there is impairment in multiple cognitive domains. And the deficits are severe enough to impair instrumental daily activities and independence. So they may need assistance with their finance, their bills, grocery, shopping. It is estimated that around 30 to 40% of the patients can have mild cognitive impairment. And in one study, it was found that patients who have normal cognitive function, about 30% of them develop mild cognitive impairment after 5 years. The prevalence of PD dementia is around 40%, but the lifelong incidence, like as frequency, can increase up to 80% of patients after 20 years of disease. However, every disease is different, and the rate of progression is also different for every individual patient. What are the risk factors for dementia? Older age of onset, disease severity, advanced disease states is associated with increased risk of dementia. Disease duration, presence of hallucinations or family history of dementia. These are the risk factors. So it is very important to recognize cognitive dysfunction and dementia in Parkinson's disease, but because it impacts their quality of life and also increases caregiver burden. Evaluation involves obtaining a good clinical history from the patient, their family, or caregivers, performing cognitive testings in the clinic, including Montreal Cognitive Assessment or mini-mental status examination, or for some patients, we often refer them to neuropsychology testing. Patients who have cognitive dysfunction should have safety assessment. There should be discussion about their driving, and also like discussion about home safety to prevent any other issues related to cognitive dysfunction. Another important aspect is always trying to identify, are there any treatable causes? Are there any abnormality in their lab workup or their imaging, like whether they have like a recent stroke causing the change in cognitive function, or reviewing their medications to identify some of the medications which can affect their cognitive functioning. Management relies on, first, it's always better to simplify their medication regimen, make sure some of the medications which can interact or cause some cognitive dysfunction should be reduced or discontinued. If they have associated depression and anxiety, that should be treated, because those mood issues can also contribute to cognitive dysfunction. There's a very important role of exercise. In several studies, it has been shown that higher lifetime physical activities associated with less cognitive decline. So patients should be involved in various forms of exercise, aerobic exercise, resistance training, or yoga, mindfulness. Whatever they feel they can do it with consistency, they should continue that. And also, like, where they should feel engaged in these exercises are helpful. Regarding diet, Mediterranean diet has been associated with reduced risk of cognitive decline. So trying to include some more fruits, vegetables in their diet, cutting down on some fatty food or red meat can be done. Regarding supplements and vitamins, there's limited evidence for the role of supplements. A lot of patients ask us about different forms of supplements, but as of now, there's very limited evidence. Recently, there was a study done at UCLA where it was a good, well-designed study where they did see an improvement in cognitive functioning in patients who were on turmeric supplements. However, more data is needed, more studies are needed to replicate that. The role of medications is also there. Medications can provide mild to moderate improvement in their cognitive functioning. Patients can be prescribed donepezil, rivastigmine, memantine, galantamine. Reviewing the medication again is important, trying to remove some of the medications which can contribute to cognitive dysfunction, including anticholinergics such as trihexyphenidyl or benztropine. Tricyclic antidepressants can be lowered or discontinued. Nortriptyline or amitriptyline, these are the examples of tricyclic antidepressant. Benzodiazepines, including clonazepam, alprazolam, these can also contribute to cognitive impairment. And even the Parkinson's medications, such as dopamine agonist, can cause worsening of cognitive functioning. The cognitive dysfunction and dementia do not respond to levodopa or other dopaminergic medications. Early on in the disease state, patients can have slow thinking, which may respond to levodopa or other dopaminergic agents. But as the cognitive impairment gets worse, these medications do not help with these symptoms. As of now, there's no medication which can slow down or modify the disease course. So it is very important for all the patients having some cognitive changes to exercise regularly. Now let's talk about the mood disorders in Parkinson's disease. It is another common non-motor manifestation in PD. Patients can have depression, anxiety. They can become passive with loss of motivation or develop apathy, which is the term we use for loss of motivation or and passivity. When that becomes severe, they can develop abulia, which is severe form of both mental and motor apathy. Depression in Parkinson's disease is common. It can affect around 30 to 50% of the patients, and it can be quite disabling, impacting their quality of life. It can be difficult to identify. So look for any patients if they develop any lack of interest or appetite changes, fatigue, sleep issues, or feeling of hopelessness. Management involves regular exercise, cognitive behavioral therapies helpful. Patients can be referred to psychologists to discuss cognitive behavioral therapies. And then medication should be tried to improve depression, including SSRIs such as sertraline, paroxetine, mirtazapine, citalopram, or tricyclic antidepressants such as nortriptyline or other medication in that category should be tried. Anxiety is also common in Parkinson's. It can affect around 1/3 of the patients. It can be present with depression. Because of anxiety, patients fear social occasions. They can have generalized anxiety or they can have panic attacks. Another important thing to remember is anxiety can be associated with off state when the medication effect wears off. So patients can not only develop motor features, including their tremor coming back or slowness coming back, but they can also develop severe anxiety where they are tearful or they can have shortness of breath feeling. So that can be reduced by adjusting the Parkinson's medications. Management of anxiety involves doing mindfulness and relaxation therapy. Cognitive behavioral therapy is again important for patients with anxiety. And then role of medications is there. Patients where anxiety is not controlled and affecting should be treated with medications, including SSRIs or benzodiazepine or risperidone. Another important non-motor manifestation is Parkinson's disease-related psychosis, which can occur as the disease progress, and it can affect around 20 to 40% of patients who are treated with dopaminergic medications. The common symptoms of psychosis includes hallucinations. Visual hallucinations are most common. Rarely they can hear sounds, can smell some things which are not there, or they can feel something. It should be, it is important to recognize hallucinations and differentiate it from illusion, which is a misperception. For example, a chair looks like a dog. Patients can also have presence hallucinations where they feel presence of somebody in the room, or they can have passage hallucinations where there's brief vision of a person or an animal passing sideways. With the disease progression or when the psychosis gets worse, they can develop delusion, which is a false belief in something. Most common is paranoid delusion, where they feel they can have symptoms of feeling that people are stealing money or intruders are living in the house or someone is planning harmful plots against them. Recognition of psychosis is important, and its treatment is very important because it impairs their quality of life, increases caregiver burden, and it is one of the greatest risk factors for nursing home placement. What are the risk factors for development of PD-associated psychosis? Presence of dementia is one of the greatest risk factors. Advanced age, longer disease duration, higher dose of anti-Parkinson's medications, depression, sleep disturbances. So controlling some of the other factors should be done early on in the disease course, particularly depression or sleep disturbances, which can be addressed. Management of PD psychosis involve identifying any precipitant, looking at any medication changes around their symptom start date. Was there any infections, for example, a urinary tract infection, or they can develop pneumonia? Was there any electrolyte abnormalities? They can from dehydration, low sodium. And then reviewing their medication to see whether some of the medications need adjustment, stopping anticholinergic agents or amantadine, which is hallucination is one of the common side effects of amantadine. Dopamine agonist also increases risk of hallucinations. And then trying to simplify their regimen, cutting down on COMT inhibitors or MAO-B inhibitors. And if even after that, the hallucination psychosis is not well controlled together, I mean, even after trying other medications, they may need reduction of levodopa. Caregivers or family members should provide reassurance or orientations to the patients. Most of the time, they do have insight that the hallucinations are not real. Medications, including pimavanserin, quetiapine, or clozapine, are helpful in reducing the psychosis symptoms. Sometimes with the disease progression, despite these measures, the management of psychosis become very challenging. And in those cases, we have to try to further reduce the medication, including levodopa, and then see which symptom is most bothersome, whether with reduction in levodopa, they can have worsening of motor features or symptoms. But sometimes we have to do that to reduce their psychosis, which are more bothersome than their motor symptoms. Sleep disturbances in Parkinson's disease is another very common non-motor manifestation. It can affect around 60 to 90% or above 90% of the patients with PD. And sleep disturbances, again, can significantly impact their quality of life. Common sleep disturbances in PD includes sleep fragmentation, insomnia, excessive daytime sleepiness, REM sleep behavior disorder, restless leg syndromes, sleep apnea. One of the most common sleep issues in Parkinson's is sleep fragmentation and insomnia. It can affect around 60% of the PD patients, where it causes nighttime sleep disturbances. Patients can have difficulty falling asleep or staying asleep, which can result in daytime fatigue and sleepiness. However, insomnia and sleep fragmentation can happen regardless of Parkinson's disease too. But in Parkinson's disease, the different causes which causes sleep fragmentation and insomnia include nocturnal Parkinson's symptoms. During the sleep, where they are in the stage of light sleep, their tremor can return, or at night their medications can wear off. They have difficulty in turning and twisting, which affect their sleep quality. Nighttime urination, frequent urination at night, wakes them up. Certain medications can cause sleep fragmentation and insomnia, including dopaminergic medications, which helps their Parkinson's motor symptoms. Underlying sleep apnea is another important factor to recognize, which can cause sleep issues and fragmentation and insomnia, and restless leg syndromes. Other causes of insomnia includes poor sleep hygiene. So that's another important big factor. Other associated mood disorder, anxiety, depression, which can affect their sleep quality, and circadian rhythm problems, where patients take frequent naps or during the day and then stay up at night. Management of insomnia and fragmentation involves developing a very good sleep hygiene. So trying to set a fixed time for sleep every night, avoiding any stimulation, for example, bright light, watching television prior to your bedtime, or using phones or iPads. Relaxation training before this sleep can be helpful for several patients. Again, exercise is important. Include some mindfulness form of exercise such as yoga, tai chi, and then cognitive behavioral therapies also can be very helpful for patients with sleep fragmentation. Medications can improve insomnia and can be very helpful for several patients. Some of the common medications which we use include melatonin, mirtazapine, trazodone, or tricyclic antidepressants such as nortriptyline or benzodiazepine, including clonazepam, Valium, alprazolam. These all can be very effective and should be utilized. One of the important, not important aspect to but one of the challenges we have is to manage the sleep fragmentation, where patients frequently wake up and they can still have the fragmentation despite the medications or sleep hygiene. As the disease progresses, that can become very bothersome to the patients. Excessive daytime sleepiness is another important sleep disturbances, which can affect around 15 to 50% of patients with Parkinson's. It is associated with disease severity, and sometimes it can be confused with fatigue, it can be challenging to differentiate between fatigue and excessive sleepiness. Excessive daytime sleepiness can be assessed by various scales, including Epworth sleepiness scales. And in some patients, we refer them for sleep study. The causes of excessive daytime sleepiness includes the disease itself. The neurodegenerative changes from Parkinson's can cause excessive daytime sleepiness. Parkinson's medications can also contribute to excessive daytime sleepiness. And then patients can also have underlying other sleep disorders, such as obstructive sleep apnea or periodic limb movement disorders. Management of excessive daytime sleepiness involves trying to address underlying causes. If they have sleep apnea, they should use CPAP, or trying to identify any medications or cutting down their dopaminergic medications, particularly dopamine agonists. Light therapies can be very helpful. Bright light, it can be, light therapy can be done by using certain light boxes which are available. Bright light exposure in the morning, or for some patients in the afternoon, can help to realign their circadian rhythm and improve their sleep issues, particularly insomnia or excessive daytime sleepiness. Certain medications can be tried, including modafinil or modafinil. Modafinil may help self-reported sleepiness, but there's no clear evidence that it improves objective sleepiness or fatigue. And in some patients, stimulants can be helpful, such as methylphenidate can be utilized. However, caution is advised for patients with cardiovascular disease, and caffeine can only provide temporary benefit. REM sleep behavior disorder is another very important aspect of sleep disturbances in Parkinson's disease, which can affect around 40 to 45% of patients with PD, and it may precede the appearance of motor symptoms by years. Patients can have violent dream enactment, which can lead to injury of patient or bed partner, and these symptoms can fluctuate over the time. It is important to assess for underlying REM sleep behavior disorders. Obtaining good clinical history from patients or their bed partners can help to identify REM sleep behavior disorders. Asking about nighttime behaviors, their movements, and then the patients can have sleep-related injury, because during the dream enactment, they can hit the table on the side or the lamp, or they can fall from the bed. In some cases, we refer patients to for sleep study, which can also again help in identifying underlying REM sleep behavior disorder. Patients with REM sleep behavior disorder should sleep in a protected environment to minimize the risk of injury. SSRI antidepressant can worsen REM sleep behavior disorder, and these are not controlled with medications. We can sometimes try to discontinue SSRI to see if that helps, or change the timing of the medication. Medications including melatonin and clonazepam are quite effective to reduce REM sleep behavior disorder. Donepezil has some evidence that it can reduce REM sleep behavior disorders, and dopamine agonists, including pramipexole, can also help in reducing REM sleep behavior disorder. Restless leg syndrome is another sleep disturbances which can bother patients with Parkinson's disease. It is an urge to move the legs, usually or not always accompanied by or caused by uncomfortable and unpleasant sensation in the legs. The urge to move or the unpleasant sensations begin or worsen during periods of rest or inactivity. So for example, in the evening or around bedtime when they're sitting. So they get this urge or uncomfortable sensation, which are partially or totally relieved by movement. So patients will prefer to move their legs or try to rub their legs, or they prefer to walk. And it is not solely accounted, we have to remember that it's not solely accounted for as symptoms due to another condition. So patients with severe neuropathy can have tingling numbness, which can cause this unusual, uncomfortable feeling in their legs. Often patients with restless leg syndrome will describe that they cannot get comfortable, they cannot fall asleep. They have this antsy feeling in their legs, or crampy feeling and tingling in legs. If that gets severe, they avoid long car rides or airplanes. Management for the restless legs is important because it can impact their quality of life, they affect their sleep, overall their mood. So role of medication is there because these can be quite effective, including gabapentin or gabapentin anacarbil, pregabalin, or long-acting dopaminergic medications are quite effective, including ropinirole, pramipexole, rotigotine patch. Opioids can be used in very severe cases where patients do not respond to other medications. Benzodiazepine also have a role in it, such as clonazepam can be tried, or alprazolam. Not very effective, but can be tried. Another important non-motor manifestation is autonomic dysfunction, which with the disease progression or even before the onset of disease, autonomic nervous system can be affected, and patients can have various symptoms related to autonomic dysfunction, including constipation, urinary dysfunction, nocturia, like nighttime urination, frequency, urgency. They can have sexual dysfunction, erectile dysfunction in males, and reduced libido in both males and females, excessive sweating, excessive salivation, drooling, orthostatic hypotension, rhinorrhea with increased nasal drainage. I would like to cover the orthostatic hypotension, which is lowering of blood pressure on standing, and the lowering of blood pressure is sustained. It is defined by a drop of around 20 points in systolic or 10 points in diastolic blood pressure when they stand up, and blood pressure is measured after 2 to 3 minutes. Majority of the patients with orthostatic hypotension are asymptomatic despite a drop in blood pressure. Patients will often complain of dizziness, or they can have episodes of passing out. They can have clouded thinking, blurred vision. They can have fatigue, neck and shoulder pains. And with the passing out or syncope, they can also have they can have bad fall. So it is very important to recognize orthostatic hypotension. If patients are having any of these symptoms, it is advised to measure their blood pressure while sitting and standing for few days at random times during the day, and see whether they are having orthostatic hypotension or drop in blood pressure. Management involves first with identification, then trying to increase water or salt intake. If their blood pressure is low, a cold glass of water can increase the blood pressure immediately. Trying to address the medication which can contribute to hypotension, avoiding large meals, alcohol, hot shower, particularly for patients who have really bothersome orthostatic hypotension. So they can be very sensitive to these things like hot shower or large meals. When they're sleeping, their end of the bed should be propped up. In patients who are symptomatic and who do not respond with conservative measures, medications should be tried, including fludrocortisone and midodrine. Both can increase the risk of supine hypertension. So where they're lying down in the evening, they can have elevated blood pressure. Droxidopa is another medications which we use for management of orthostatic hypotension. Pyridostigmine can be tried. It has some limited evidence that it can help to improve orthostatic hypotension. Now, I would like to cover sensory symptoms, which can occur in patients with Parkinson's disease. Anosmia, which is loss of sense of smell, can predate motor symptoms by a decade or longer. It's one of the common sensory symptoms. Pain is another common sensory symptoms. Patients can also have paresthesia, numbness, burning, which is less common as compared to pain or anosmia. Patients can also have akathisia, where they feel a sense of inner restlessness or discomfort, which is relieved by walking. And akathisia can also occur in during off periods, or it can be a side effect of levodopa. So it's important to recognize when it's occurring with respect to timing of medication. In terms of pain in Parkinson's, patients can have aching, boring pain in the affected limb. And these can, the pain can be quite bothersome to the patient, and it can affect around 30 to 40% of patients with Parkinson's. And the pain can occur even before the onset of motor symptoms. So a lot of time patients will have some shoulder pain, arm pain, and later on they develop tremors or stiffness or slowness of that involved limb. Dystonia is another important symptoms where patients have overcontraction of the muscle. They can have dystonic cramps. Usually it can occur early in the morning or during off periods, or they can have dystonia with Parkinson's. Pain can also be secondary to Levodopa or the dopamine agonist. So a lot of patients describe that after they take medications, they have leg pain, or they can develop this pain in their arms. So it is important to recognize whether the pain is occurring after intake of medication. And other important thing to understand that pain can be from other underlying causes too, for example, arthritic changes or musculoskeletal changes. But typically pain from Parkinson's disease improves with Parkinsonian medication. So that's how we try to differentiate if the pain is coming from underlying Parkinson's disease. We often ask patients whether the pain is responding to medications, whether the pain is occurring during off time or after taking the medications. Management of pain for patients where pain is primarily part of their off time, trying to reduce off time by medication adjustment. Patients with dystonic cramps or dystonia, they can respond very well to botulinum toxin. Central pain, including burning, tingling, respond to medications including gabapentin, amitriptyline, nortriptyline, which can be tried. And then radicular pain, once it's identified or pain related to arthritic changes, patients are referred to physical therapy, occupational therapy, or spine physicians for back issues to see if they can be candidate for any decompressive surgery. Now, lastly, I will briefly touch on fatigue, which is another common non-motor manifestation of Parkinson's, which can affect around 40% of the patients. And it can be an independent symptom of Parkinson's disease or can be associated with other symptoms, including depression or sleepiness. Patients can have fatigue even before the onset of their motor symptoms. A lot of time early on in the disease course, where the motor symptoms are minimal, they can have a lot of fatigue. It can be challenging to treat. Trying to identifying underlying depression or daytime sleepiness and addressing those symptoms which contribute to fatigue can reduce fatigue. Also identify certain medications or other medical conditions which can contribute to fatigue. For example, I often check for, is there any vitamin D deficiency or B12 deficiency, or are there other medical conditions such as hypothyroidism, or they're anemic, because all these factors can also contribute to fatigue. There's a limited evidence regarding medications for fatigue. Some studies have shown that methylphenidate, which is a stimulant, can help patients with fatigue. So that can be tried. But again, caution is advised in patients with cardiovascular risk. So I think with that, I will conclude this talk, and I'll be happy to take any questions regarding non-motor symptoms. Thank you.
Thank you, Dr. Sharma. And we actually, that's a great segue into our Q&A portion of the program, where we're pleased to welcome Dr. Rajesh Pahwa and Dr. Kelly Lyons. Dr. Pahwa is the Laverne and Joyce Ryder Professor of Neurology, the Chief of the Parkinson's and Movement Disorder Division, and Director of the Parkinson's Foundation Center of Excellence at the University of Kansas Medical Center. Dr. Pahwa's research interests are centered around the various aspects of Parkinson's disease and essential tremor, and he has published more than 250 peer-reviewed articles, chapters, and abstracts in leading neurology journals. He also has conducted more than 75 clinical trials related to Parkinson's disease and other movement disorders. We're also very pleased to welcome our guest moderator, Dr. Kelly Lyons, who is the Director of Research and Education at the clinic and co-director of the Parkinson's Foundation Center of Excellence. Kelly's areas of research include Parkinson's disease and essential tremor as well. She has more than 200 articles and presentations in these areas. I'm now going to hand it over to Dr. Lyons to lead our speakers in a Q&A panel.
Hey, thank you, Kim, and thank you all for attending. We're excited to see so many people here today and wish we could have been here with you in person. But we have a lot of questions, so I think we'll get started. And the first question for Dr. Pahwa is, can you talk a little bit about promising treatments, studies that may be going on, or kind of what's the future for Parkinson's right now?
Yes, thank you. So that's a very important question because everyone wants to know where the future is and how close we might be to actually trying to win over this disease. What I can tell you is right now, the number of studies that are going on in Parkinson's is really at its all-time high. Some of the challenges, of course, come down to is what we are testing today. We don't know how much of those will actually make it into practice in the future. So let me start off by telling you some of the ones which would be the closest to getting approval. One of them, as Dr. Au mentioned, is apomorphine-based therapies. We right now have apomorphine injections and strip, and the next big thing is apomorphine infusion, which would be subcutaneous. So for patients with Parkinson's disease who are having off time or motor fluctuations, imagine having a subcutaneous medication that provides continuous control throughout the day, and in some cases also at night. So we expect a subcutaneous apomorphine infusion hopefully will be approved in the next year. In the next couple of years, just like subcutaneous apomorphine infusion, we are hoping subcutaneous levodopa infusion therapies would also be approved. So again, these would be more in patients with advanced disease who are having off time, and in patients who are not candidates for deep brain stimulation or who don't want to have surgery. This would be a very good alternative for them. The other things are some of the things which we are testing today in very early studies involve both for trying to slow the disease progression, as well to help symptoms of off, as well as to help symptoms of dyskinesias. What I will do is send you a newsletter at the end of our presentation, which will include some of these studies that are ongoing. Just in general, to give you an idea, we are testing medications to slow the disease progression. And usually when we look at medications to slow disease progression, we are looking at patients before they actually get on medications, because once a patient starts medications to help their symptoms, it becomes very difficult to trying to differentiate what is improving underneath with the disease. So these studies are really related to actually people with early disease not currently on medications. Right now, these studies are focusing on a protein called synuclein in the brain. And there is a thinking out there that synuclein might be damaging the cells resulting in Parkinson's. And if in some way we can clear this protein in the brain, we may be able to slow Parkinson's. So that's the basis of some of these early therapies that are being looked at slowing disease progression. One of these therapies is actually going to be studied in patients who are already on levodopa. So just because someone has started levodopa doesn't mean they may not completely qualify for that. However, again, it has to be early disease, not someone with Parkinson's for a long time. The other thing is, like I mentioned, the subcutaneous infusion therapies. We are right now doing studies in patients who have off time, looking at these subcutaneous levodopa therapies to reduce off time. Similarly, you heard about dopamine agonists being used both in early disease as well as in patients with off time. And again, we are testing medications, which is a new dopamine agonist, which we are hoping may not have as many side effects as the current dopamine agonist. Again, both in patients who are starting on medications and then patients who are having off time. The other one is patients with dyskinesias. Those are involuntary movements related to levodopa. Right now, there's only one medication approved for dyskinesias. However, we are studying two very promising drugs for dyskinesia. So again, if you're having dyskinesias which are affecting you, you could potentially be candidates for this therapy. The next group of therapies that we are looking at is actually gene therapy. And two of the main gene therapies we are going to be involved with is one is in patients who have the gene LAR2. And this therapy is specifically for patients who have this specific abnormal gene in their body. And the other one is actually injecting genes in the brain so as to replace some of the neurotransmitters such as dopamine and glutamate. So like I said, this is just the tip of the iceberg. There are a lot more studies which are very promising, which are being studied in Parkinson's, but this is kind of to give you an overall view of what's going on.
I'm sorry, I was muted. Dr. Pahwa, there has been a lot of talk about gene studies and biomarker studies. Is this something that you're doing at KU?
Right. So, what I talk about genes and Parkinson's is where cancer used to be a few years ago, that's where we are with Parkinson's. Today, if a person has cancer, they can actually look at the genes and give them specific drugs depending upon if they have some genetic markers. So the first thing we need to look at is, are patients with Parkinson's and what kind of genes do they have? And then look at it, how these genes affect treatment and whether we can come up with specific treatment based on the genes. So right now, as someone mentioned earlier, we are doing the PD gene therapy, where pretty much any patient who's interested at no cost, we are actually checking if they have one of the common genes for Parkinson's. Of course, this is the first step in a long process that which we are going to go for. Like I said, one of the genes is LAR2, which is being tested with PD genes. So if you're interested, get yourself tested. We are finding approximately 10 to 15% of our patients who are being tested have one of the common genes for Parkinson's. Once a patient has a gene, then like I said, for example, the LAR2 study would be specific for them. But we are also finding another gene, for example, the GBA gene, which has a very interesting course in Parkinson's, very different from what a Parkin gene patient and a LAR2 patient might be. And again, these therapies would help us guide therapies for the future. Another big biomarker study we are doing is the PPMI study, which is funded by Michael J. Fox. And this study, we are looking at multiple biomarkers, including doing a little bit of CSF. Again, checking CSF or getting a sample of CSF is very simple. It's just like getting blood, except instead of your vein, a needle is stuck in your back to get a little bit of CSF sample. We're also doing skin biopsies, both as part of research, as well as in some patients where we are not sure if they indeed have Parkinson's disease or they may have a form of Parkinson's. So again, other than medications, we are looking at a lot of biomarkers, which will help us in the future have more specific and customized treatment for Parkinson's patients.
Thank you. And just to add to that, if people are interested in any of these studies or want more information or specifics about recruitment or eligibility, they can email us at pdetcenter@kumc.edu. And Kim will also send this information out after the program, so you have that email to get more specifics about the study. And for the gene studies, you don't have to have a family history, only a diagnosis of Parkinson's disease to participate. I think the next question I'd like to address to Dr. Au, could you talk a little bit about how protein can interfere or is related to the medications that people take for Parkinson's disease?
Yeah, absolutely. So there is some data to show that in conjunction, when you're taking levodopa, carbidopa-levodopa, that protein can sometimes interfere with the absorption of the levodopa. So you can get kind of an unpredictable response, especially if you're having a heavy protein meal shortly after or before taking your carbidopa-levodopa. It doesn't happen early on, but it can happen in some people where they really notice it. So for that, we would suggest that you kind of space out your medications either half an hour before or half an hour after you have a heavy protein meal to kind of avoid this type of complication.
Thank you. And Dr. Sharma, there's several questions about deep brain stimulation. One, does deep brain stimulation improve difficulty with walking in balance and freezing, or can it actually make those worse? Dr. Sharma, I think you're on.
Yeah. Oh, sorry. So, regarding the balance issues, the deep brain stimulation is not effective to improve balance until unless the balance is primarily a issue is coming from severe bradykiniasias. So we often look at the response of levodopa and to predict whether the patients can have improvement in their walking after deep brain stimulation or not. But once with the disease progression, their balance center is affected and they start to develop postural instability, deep brain stimulation is not effective. And regarding, I think the second point was related to the breathing.
Freezing.
Freezing, okay, I heard breathing. Yeah, so same thing with the freezing of gait. Deep brain stimulation can be effective for patients where the freezing respond well to levodopa. But as the disease progress and their freezing become non-responsive to levodopa, then deep brain stimulation will have limited effect. With our experience, like I have seen a lot of patients where their freezing was improving with levodopa, but after deep brain stimulation surgery, they had transient improvement, and as over the time they start to develop worsening of freezing of gait. It is not, I mean, mostly I feel that's more related to disease progression, but in some patients I've seen the decline could be rapid. So suggesting deep brain stimulation can have some impact on worsening, but particularly the balance issues, which has been shown in studies, which is more with a particular target. For example, STN more as compared to globus pallidus target.
Okay, thank you. Dr. Pahwa, could you speak to the other forms of Parkinsonism, a little bit about what those forms are and how they differ from typical Parkinson's disease?
Yes. So when we talk about Parkinson, we are basically talking about symptoms of tremor, bradykinesia or slowness, rigidity or stiffness, and postural instability or balance. The most common cause of Parkinsonism is Parkinson's disease. So anyone who walks in my clinic, and even if I don't look at that and say they have Parkinson's disease, I'm going to be correct 75 to 80% of the time, because 75 to 80% of the patients with Parkinsonism do have Parkinson's disease. The other group of patients when we talk about they could have another form of neurodegenerative condition. In other words, they could still have a degenerative condition in the brain. And these could include people who may have what we call Lewy body dementia. Lewy body dementia is patients in whom Parkinsonism and dementia often begin around the same time or close to one another. So again, they can have very typical features of Parkinson's, but they have early cognitive issues and early hallucinations. The other group of drugs is what we call multiple system atrophy. Now, multiple system atrophy earlier on can look very much like Parkinson's disease. They usually don't have as much tremor. They usually have walking and balance difficulties and falls, which start much earlier. And usually they don't respond to Parkinson medications. If they do respond to Parkinson medication, the response is only for about a year or two. It's extremely rare that these patients respond long-term. Other than multiple system atrophy, the other group of commonly seen atypical Parkinson's is progressive supranuclear palsy. PSP, as it is commonly called, again starts with balance difficulties, especially falls. But again, they can have slowness, they can have stiffness, they can have walking difficulty. And their typical features are they have eye movement abnormalities. In other words, their eyes don't move very well. And they have very typical findings on their MRI. So again, if an MRI is done, it may help decide whether they indeed have PSP or not. Then you have essential tremor. Often if a patient purely has tremors, especially if they're elderly and have some walking and balance difficulties, they can be often misdiagnosed as Parkinson's rather than essential tremor. In essential tremor, they usually have tremor while they're doing stuff, like while they're writing, while they're eating. And usually their handwriting does not get small, which typically we see with Parkinson's. But again, essential tremor at times can be mistaken for Parkinson's. Then there are some other brain abnormalities can look like Parkinson's. For example, people with multiple strokes or people with strokes in the area where Parkinson's begin. There might be normal pressure hydrocephalus where they have excessive CSF in the brain that is pushing the brain. They could have brain tumors rarely, which can look like Parkinson's. So there can be a whole bunch of other conditions that can look like Parkinson's. Then, of course, you have medications, especially psychiatric medications like Haldol, Thorazine, which can again cause symptoms very much like Parkinson's. The good thing with medications is that once you discontinue the medication, it may take 6 months, it may take 8 months, but these symptoms will resolve if the medications are causing it. And finally, certain chemicals and toxins can cause atypical Parkinson's. So again, you have multiple other conditions that can look like Parkinson's disease, but may not be Parkinson's disease. But this group makes up a small number overall in the total cases that we have with Parkinson's.
Thank you. Dr. Au, can botulinum toxin, when used around the eyes, cause trouble with swallowing?
Thanks for that. Not typically. I mean, it's always a risk that, so we inject a very small amount. It's in a very small amount of fluid. And the reason why we do the injection is so that we can target the muscles. The swallowing muscle apparatus is kind of in the neck area. And if we're doing it around the eyes, typically it doesn't, there's a little bit of local diffusion of it, but usually it doesn't extend all the way down to the muscles that help you with swallowing. So for the eyes, I wouldn't say that would be common. If you have Parkinson's disease as well as cervical dystonia with Parkinson's disease, sometimes in the neck area, that's when you might be a little bit more concerned about swallowing problems. But as we inject and utilize botulinum toxin, with somebody experienced, they would try to go higher up in different areas to avoid that swallowing complication.
Thank you. Dr. Pahwa, there's several questions about after taking medication, people are getting a pounding heartbeat, difficulty breathing, tightness in the chest. Is that normal? And is that related to the medication itself?
So of course, any medication can potentially have side effects. So anytime you start a new medication, you need to make sure it is not the medication causing it. But in general, Parkinson's medications would not cause the symptoms that you just described, for example, pounding in the chest. They sound more like anxiety. The issue comes, can Parkinson medications cause anxiety? Again, it's really extremely rare. But like I said, anytime you start a new medication, you need to be aware of anything new that happens and make sure it's not the medication doing it.
Okay, and Dr. Paul, could you also discuss, is taking B12 and folate something someone with Parkinson's disease should be doing?
So it is really, once a patient is on levodopa, we recommend that if they want to use any vitamins, folic acid and B12 might be a couple of them to consider. Because the thing is, once patients on levodopa, there are certain chemicals that can go up in the bloodstream, and they can potentially increase a small risk of having stroke-like symptoms. So because of that, we recommend, at times using folic acid might be helpful in these patients. Unless you have B12 deficiency, again, you don't need to use B12. But again, it is something to keep in mind that majority of our elderly patients often have some degree of low B12 and vitamin D, especially in Midwest. So those would be a few of the vitamins to consider if patients want to take any.
Okay, thank you. Dr. Sharma, you mentioned to try to have good sleep hygiene. What is poor sleep hygiene? What should people avoid?
So yeah, that's a very good question. And for the sleep issues, one of the most important thing is maintaining a very good sleep hygiene. And in the management, that's the top three things, like basically sleep hygiene, sleep hygiene, sleep hygiene. That's what can help. So what are the important factors and things which is a part of good sleep hygiene? One most important thing is fixing a time for your bed. So every day, so that your circadian rhythm is well regulated. So finding a time where you should, it could be like for early on 8, 9 p.m., 10 p.m. for any patient, but trying to go to bed at same time every night. Second is avoiding any activities which can stimulate your brain. For example, watching television before the bedtime, or reading on iPads or tablets, or using phone. These days they have these blue light filters because the blue light activates your brain. So you can turn on the blue light filters. And then avoiding exercise before the bedtime. That's another thing which can stimulate your brain, and that should be avoided. Patients can also try to do certain relaxation techniques, like deep breathing, or there are like several techniques which can be taught by a psychologist or as a part of cognitive behavioral therapy. And I think other thing is to improve sleep hygiene is like getting exposure to the sunlight. If that's not possible, getting exposure to bright light therapy, which can be very effective and helpful to improve sleep disturbances.
Thank you.
If there's anything, I think that's kind of like most of the things. Thank you.
Mm-hmm. Dr. Pahwa, I have a few questions about tremor. The first question is it possible to only have tremor and no other Parkinson's symptoms?
So firstly, the issue comes down to, do they actually have Parkinson's or they have essential tremor, like I mentioned earlier. And usually with essential tremor, patients have tremor more when they are eating, drinking, writing, and usually in Parkinson's, it's when they're just sitting. That's when the tremor is present. At times, it can be difficult to differentiate if a patient does have essential tremor or a patient has Parkinson's tremor. And doing a test like DAT scan, could help differentiate those conditions, because with essential tremor, the DAT scan is going to be normal. And in Parkinson's, the DAT scan is going to be abnormal. Now, rarely patients can have what looks like slowness and tremor but the DAT scan could be completely normal, but this tremor is not there while they're writing stuff or while they're doing stuff. Then the question comes back is, what is the tremor from, especially if the DAT scan is normal? The issue again comes down to maybe their symptoms are very early, that the DAT scan may not be still capturing it, or there's another form of tremor called dystonic tremor, where they have some degree of dystonia, which may look like slowness, but is actually dystonia along with tremor rather than Parkinson's tremor. Now, one other form of it is which we call tremor predominant Parkinson's, where their main symptom is tremor. They have a lot of resting tremor. They could even have tremor while they're doing stuff. But when you try to look for the bradykinesia and rigidity, they have very little of the other things, and they usually progress very slowly. However, they still progress. So even at 10 years, you may see that mainly have tremor with very little bradykinesia, very little gait changes. Again, these patients would still have an abnormal DAT scan. So tremor predominant PD in a way is good because really the main symptom is tremor with very little other symptoms. It progresses very slowly, but unfortunately, over time, it still progresses. So my impression is the person who asked the question was trying to see, can they have tremor predominant PD versus Parkinson's disease?
Okay. Can someone have essential tremor that eventually develops into Parkinson's disease, or are those two separate disorders?
So that is a very good question, and there's a lot of controversy related to that. First of all, essential tremor is a very common condition. It's 10 times as common as Parkinson's. So a patient is much more likely to have essential tremor versus Parkinson's. Can someone by chance have both, have essential tremor for 10 years and then develop Parkinson's? Yes, of course they can. The question here is more like, if someone has essential tremors, are they more likely down the road to develop Parkinson's more than by chance? Unless we have better biomarkers, it's going to be difficult to answer that question, because right now I would say we as experts are split. There is a group that believes that it could be that people with essential tremor are more likely to have Parkinson's, but another group like me believes no, it is more by chance than it is that they are more likely to develop Parkinson's. I would focus that if someone has essential tremor, that is what they have. If they develop Parkinson's, it's most likely unrelated, rather than if someone has essential tremor, they be concerned that down the road that they may develop Parkinson's disease.
Thank you. And this last question about tremors kind of reversed, because what if, can you not have tremor and have other symptoms that are very mild? And if, say, 10 plus years, those symptoms really don't progress much, do you go into remission with Parkinson's, or how does that work?
So first of all, if someone has Parkinson's disease, they cannot go into remission, at least not yet. We don't have anything that we can reverse or cure it. Like I said, patients could be on medications that cause Parkinson's. They stop the medication and the Parkinson's may go away. But if someone is diagnosed with Parkinson's disease, that's not going to go away. The question about, can you have Parkinson's disease without tremors? Yes, you can. About 20% or so patients can have Parkinson's disease and do not have any tremor throughout the disease course. The thing is, every patient with Parkinson's is unique. When we talk about there is one patient with Parkinson's we have seen, we mean that that's the way that person is. A different person may have completely different symptoms. So can you see a patient who doesn't have tremor but was diagnosed with Parkinson's disease and it goes very slowly over 10 years? Yes, it can happen.
Okay, thank you. Dr. Au, does stress worsen the symptoms of Parkinson's disease?
Yes, absolutely. With stress, any type of stress. So certainly you can have like a physical stress. If you have your body's fighting off an infection or another illness, often and commonly urinary tract infection, that's stress on the body. You're getting treatment for something else. You have a, pain for another reason, another medical condition. You're going through a surgery that can worsen the symptoms of Parkinson's disease. And then also psychosocial stress, things going on in your life. If you have anxiety on top of that, that can worsen the symptoms. People often describe worsened slowness and stiffness during this time. And especially in the past year, many of our patients with the added stress of all that's been going on with the COVID-19 pandemic, that has also played a role in, people have found that their symptoms are worse. The medications don't seem to be as working as well, but that definitely can have an impact on symptoms.
Okay, thank you. Dr. Sharma, what is dysphagia, and does this have to do with excess saliva?
So that's another important non-motor, or you can call it like related to motor dysfunction, actually more in Parkinson's patients. So dysphagia is basically they have trouble swallowing the food down, and it can occur at the level of the musculature where the muscles are coordinated for your swallow function, or it can also occur because of dysmotility of the food pipe. So both of them are classified under dysphagia. It is important to recognize which is the primary issue. Most of the patients, as they advance, they can have dysphagia because of the improper coordination of the swallowing muscles. But some patients also have dysmotility of the esophagus. Some patients can respond to medications, dopaminergic medications, where they feel like their swallowing issues are more during their off time. So in those patients, trying to reduce their off time or optimizing their medication can help. But oftentimes, these are not very effective strategies. So we refer our patients to a speech therapist, where they evaluate their swallowing function, trying to see if they are having some aspiration, because that increases the risk of pneumonia. And they will advise them certain strategies, trying to take small bites, cut down food into small pieces, or sometimes they will ask them to modify their diet to avoid like hard solid food or switching to a thin liquid diet. So that's how that's managed. And it is important to manage it because it increases risk of pneumonia. It can be independent from excess drooling. Drooling by itself may not be contributing to dysphagia, but it is important to address drooling also because it can increase the risk of aspiration.
Thank you. Dr. Pahwa, if you were going to pick 3 things that you could tell someone with Parkinson's disease to do to make themselves as healthy as possible, what would you tell them?
So the first thing, and people who have attended our programs in the past, I always say, which again, you heard it from Dr. Au, is stay active, stay physically, mentally fit. Put aside some time every day, no matter how busy you are, to stay physically doing activities. Doesn't cost a penny, will make your Parkinson's much, much better. The second thing, which also doesn't cost a penny, is water. Majority of our Parkinson's patients do not drink enough water. Not drinking water really can affect the blood pressure, like you heard about orthostatic hypertension, can cause more confusion in elderly patients, can cause hallucinations, can make a patient just feel tired. So there are so many non-motor symptoms that occurs when a patient or person, including me, who doesn't drink enough water. So again, doesn't cost a penny. I know a lot of our elderly patients don't want to drink a lot of water is because they'll have to go to the bathroom multiple times. But unless there is a specific medical reason that they cannot drink water, in general, they should drink at least 8 to 10 glasses a day. So it's extremely important that the patients take their water intake and make sure they're drinking enough. My third thing would be make sure you take your medications and you take them on schedule as your physician has recommended. Because often we have patients who forget to take their medications and then they have off. If you start doing it once you make the diagnosis, when the time you are taking the medication may not be important, as the disease progresses, as patients start having motor fluctuations, once you have made that a habit, is going to make a big difference. So to me, the three main things would be exercise, both physical and mental, plenty of water, and three, make sure you take your medications and you take your medications on schedule as recommended by a physician.
Hey, Dr. Pahwa, does Parkinson's disease affect vision, or can it affect vision?
So both Parkinson's and Parkinson's medications can definitely affect vision. So one of the most common things that happens with Parkinson's is patients don't blink enough, and what that causes is dryness of eyes. And once you have dryness of eyes, it basically makes a film on your cornea so everything can be blurry. So pretty much using artificial tears multiple times a day, 4, 5, 6 times, no matter how many times a day, will help with this. And this is one of the most common reasons why patients have vision problems. The other thing that happens is the contrast and depth vision can get affected in Parkinson's. So when you just look at vision acuity, it looks like your vision is still 20/20 because some of these other things are not checked. And that again can be cause problems with balance, falling, and just not having a good eyesight. The other thing is double vision. A lot of our patients complain of double vision, which can occur due to Parkinson's or due to the medications, and seeing a neuro-ophthalmologist who might help them with prisms might help. But in majority of the cases, Parkinson's patients, when they complain of vision problems, there are no medications that we can give them, no medications we can prescribe. So you have to be careful once the vision problems develop, get a good assessment, get a good evaluation, and see if there are things that can be corrected.
Thank you. Dr. Au, for someone with Parkinson's disease, how often can they take Carbidopa, Levodopa, and for how long can you take that medication?
Yeah, that's a great question. So for how long can you take it? You can, even in advanced stages of Parkinson's disease, people continue to get benefit from taking the Carbidopa, Levodopa. And in some cases, that's, most important at that point, because that's, when they have the most amount of dopamine loss in the brain. How often really is individualized. As Dr. Pahwa mentioned earlier, like at the beginning of the course of Parkinson's disease, the timing isn't as important. Often, as I said, we start one tablet 3 times a day. We start just for ease, during meal times. But as the disease progresses, you often will need to bring down that frequency as there's more wearing off. And people, previously taking it every 5 hours, every 6 hours, over time it can become more frequent, and you're taking a few more dosages, even up to every 2 to 3 hours. But again, it's all individualized, and that's, you can take it even up to every 2 hours, or some people that I've seen, but you would want to discuss that with your physician, and based on your own symptoms and how the medication is absorbed in your body.
Thank you. Dr. Pahwa, how important is it to start medications as soon as you get a diagnosis of Parkinson's disease?
So Parkinson's disease is a progressive disease. If someone doesn't do anything, the disease is going to progress. In other words, 6 months later, the symptoms are going to be worse. 1 year later, the symptoms are going to be worse. The thing is, once a person is diagnosed with Parkinson's, they need to do something. And why saying they need to do something, I'm saying maybe even just exercise. Exercise, like I just said, is therapy. You need to start doing something rather than saying, okay, these symptoms don't bother me and I'm not going to do anything. So that's the first most important thing that people need to remember, is just because their symptom doesn't bother them doesn't mean they don't need to do anything. Maybe they don't need to take medications. When someone wants to take a medication, often depends on the patient and their physician. Like I said, the symptoms are going to get worse in 6 months, a year. We don't want people to think that just because the symptoms are not bothersome, that they should not start medication. The reason being, today, maybe someone only has a thumb tremor. 6 months down the road, it may be a hand tremor. A year down the road, maybe their other hand is also tremoring. Then what happens is the person said, oh, my doctor said you don't need to take a medication until it really affects you. Pretty soon they're having difficulty doing buttons, and the caregiver is doing buttons. Pretty soon the balance is affected. They're using a cane. They're saying, oh, I'm using a cane. I'm 70 years old. I don't need medicine. No. So that's what I'm saying. There needs to be a time limit, because things are going to progress if they don't do anything. Today, we don't have any medication that we can say for sure does not slow Parkinson's. But when we talk about the drugs in general, MAO-B inhibitors, for example, where we talk about rasagiline, selegiline, keep the person's own dopamine around longer. They have very few side effects. So if someone doesn't want to take anything, that could be a reasonable option to start taking. The other thing, like I mentioned earlier, is we are doing clinical trials to slow the disease progression. So again, if someone would say, I would rather not take any medication, being part of clinical trials is also helpful, because we know even in the group of patients who get a placebo, that's basically an inactive product, they still do better than not taking anything. So what I say is, what you decide is between you and your physician, but there are things you need to start doing as soon as you're diagnosed with Parkinson's.
Thank you. Dr. Sharma, can someone do too much exercise?
That's a question which has been asked like frequently, but again, with the exercise, in terms of the amount of can someone do too much, I don't think so that there are any studies, but one has to use their best judgment. Obviously, we don't want them to overexert themselves and, or cause some injury to their back or something. But I recommend they should do at least like 30 to 40 minutes, 3 to 4 times a week. And if they are doing more and they are capable of doing more, that is totally fine. I don't think there's any limit, but obviously use their best judgment and not to avoid injuring or overexerting themselves.
Thank you. Dr. Pahwa, Dr. Sharma had mentioned orthostatic hypotension, or the drop in blood pressure either after eating or on standing and that sort of thing. What is your best choice of treatment when that occurs?
So first of all, a patient can have orthostatic hypotension without having any symptoms. As people get older, the body does not react fast enough to control our blood pressure when we stand. Normally, when we stand, our blood pressure drops within seconds to a minute. Our body reacts to it. And before we can have any symptoms, our blood pressure regulates and we don't get dizzy or lightheaded. So the thing is, even when the blood pressure drops, the issue is your brain getting enough blood or not? If your brain is getting enough blood, you won't have any symptoms. But if you're not having enough blood going to your brain or your lungs or your eyes, you can have vision problems, you can have dizziness, you can have lightheadedness, and you can even pass out. So the first thing we need to do is a patient who has orthostatic hypertension or has symptoms of orthostatic hypertension is check what medications that they're taking. And the most common thing that happens is patients are taking medications for high blood pressure, and they may not need as much medications, or they may not need medications for high blood pressure at all. Once a patient develops orthostatic hypertension, it can be very challenging to keep the blood pressure at a perfect level where it is not too high or too low. So the thing is, when they have high blood pressure, they are on medications. Majority of the physicians, when they go see their cardiologists or internists, only check their blood pressure when they're sitting. And they want to say, oh, your blood pressure is fine, you're taking medications, continue to take it. But what happens in that person is when they stand up, the blood pressure drops and they get lightheaded. So that's the first thing they need to do. And if that's the case, the blood pressure medications need to be reduced. There are other medications too, including Parkinson's medications that can also lower blood pressure. So again, the thing is there any medication that can be adjusted to reduce the lightheadedness? Then, like I mentioned earlier, water and salt intake. People need to drink plenty of water. If needed, take extra salt or salty snacks, because those are the other things that would help the blood pressure. They can wear tight stockings. Higher the stocking, better the blood pressure. In other words, if the stocking is up to waist, that's better than the thigh. That's better than above the knee. And below the knee, it really is not going to help much raising the blood pressure. A lot of patients don't like to wear stockings, and they can try using abdominal binders, which can also help raise the blood pressure. Patients who, in spite of all this, continue to have orthostatic hypotension, again, there were medications that were described. The medications I personally try to use is either midodrine or using Northera, or the two medications, that's doxydropa, because those are medications which raise the blood pressure and are approved for the use of either lightheadedness or to raise the blood pressure. The other one is fludrocortisone, which keeps your fluids around longer. So you need to make sure you don't have heart conditions, because if too much fluid is retained, the heart can get affected and patients can have heart failure. So if patients are on fludrocortisone, if they realize they are gaining weight or if their feet are swelling, it might mean that, again, that they are retaining fluid. The other thing is we are testing medications that I didn't mention earlier for orthostatic hypotension. So that is another good option to consider, is taking part in trials for orthostatic hypertension. But again, orthostatic hypotension can be very challenging, especially in warm months of summer, because people are not drinking enough water. It's hot outside and inside. They're sweating a lot, and that's very common when patients who are orthostatic start medications for orthostasis. And when winter comes, suddenly their blood pressure is too high and they need to stop their medications for orthostatic hypertension.
I think one final question for you, Dr. Pahwa, before our final wrap up. If you can give the audience some advice, how can they make the most of their doctor's visit to their Parkinson's specialist? What can they do to make that the most productive visit possible?
So you heard a lot about Parkinson's today. Parkinson's is not just tremor, it's just not slowness, it's not just walking difficulty. It's a whole group of symptoms that you are seeing. So the first thing would be is, one, make sure you have your medication list with you. And if you're not sure, just take your medication bottles with you. So whoever is taking you behind to your room can check and make sure you're taking the correct medications that have been prescribed. The second thing is, take the list of symptoms that you're having and a list of questions that you have. Write it down and take it with you. We talked about a lot of these symptoms today. See if you have them, or at least make sure you put it, memory, doing good. Hallucinations, don't have any. Lightheadedness, have it rarely. Do I have any other symptoms? Check how well the medications are working. Are they having off time? If they're having off time, when is their off time? Are they having dyskinesias? If they're having dyskinesias, are there specific time they're having dyskinesias? Are they having falls? Is there a reason they're falling? Are they doing things they should not be doing? Are they using like a cane or a walker when they go to the clinic? And are they using that in spite of having the falls? How active are they? Are they physically exercising? Are they having constipation? Are they having urinary issues? Are they having sleep issues? Are they having any compulsions? Do they feel like they're gambling, shopping, eating? Are they having depression, anxiety? I know this is a long list, but putting all that on the paper when you go in and going over with your physician will help use your time well with the physician, because they can look at it and say, okay, you're doing really good, but let's say you're having a lot of off time or you're having a lot of dyskinesias. Let's see how we can improve those. And if they already have your medication list, how active you are, when you last did physical therapy, you'll get the most out of your visit. And finally, write down the questions. Don't go to the parking lot and say, oh, I completely forgot to ask those. Write down your questions and make sure they are answered. Make sure they're answered to your satisfaction. Don't let your physician just say, okay, and skip over that question. Ask them, I have this question. Could you please clarify for me, whatever is it, why I'm taking this medication? Why am I only taking it 4 times a day when my medication is only working for 2 hours? Why can't I start on-demand therapy? Why I can't change my medications? All these are questions, discussions you should have with your physician to get an idea and to get the best, not only of your visit, but to get the best control about your Parkinson's. Thank you.
Thank you. I think I have a few comments and then Kim will wrap us up today. First, thank you for attending, and we're all hoping next year we'll be able to see you in person. There were a lot of questions today that we weren't able to get to. Many of those were about deep brain stimulation and focused ultrasound. I believe that we will plan to do a program specifically on those topics in the future, so we will get those questions answered. If you have a burning question that we missed today, you can email us at pdetcenter@kumc.edu. As Dr. Pahwa mentioned at the end, when you get messages in another week or two from the foundation, you will get a copy of our newsletter. If that's not something you're already getting from us by email, please send an email to us, which is on the newsletter, so we can get you added to that list to receive the updated information about Parkinson's in our area. I also wanted to mention that there's a wealth of information out there from the Parkinson's Foundation at parkinson.org. There's many, many programs that you should look into, resources, booklets. And we also have an organization associated with the KU Health System's Turning Point. And Turning Point also offers multiple programs that you may be interested in that may be beneficial for you. The easiest way to find those is to go to just Google Turning Point Kansas City, and the website will come up with a listing of their calendar and programs. So thank you again for joining us, and I'll turn it back over to Kim to wrap us up.
Thank you so much, Dr. Lyons. And we will be sharing a link to KU's Turning Point in our follow-up documents. We really want to thank all of our speakers today. Incredibly valuable to have you sharing your time and expertise with our community. Please know to our attendees, your feedback is vital to our future programs, like Dr. Lyons mentioned. And so we would ask you to stay on just for another moment at the end to complete a survey and give us your feedback about today as we wrap up. Kelly mentioned that there were questions that didn't get answered, so feel free to email either KU, or you can always contact our helpline and they will help guide you. I also really want to thank again the sponsors for today's program, Boston Scientific and Synovian as gold, and then our silver sponsors, AbbVie, Acadia, Adamas, Amneal, Medtronic, Neurocrene, Kyowa Kirin, and Accorda. And please do visit our website after the program to check out their educational resources. And then, of course, staying engaged in the community. We've talked a lot about engagement today, so we've got some great things coming up. Next Wednesday, for any care partners, we're actually having a DBS Care Partner Town Hall. So we'll have a clinician as well as some care partners who give care to somebody living with DBS. Even if you're just considering it, it is a good opportunity and an interactive environment to join us. You can register at parkinson.org/pdhealth. And then our PD Health at Home programs take place every week. So feel free to join us. Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. And then our expert briefings were just announced. Those are 6 times a year. And you'll see here on the screen that our first one on September 1st is about progression of Parkinson's. So I know that that's often a interesting topic to folks. So we do hope to see you again soon. Please take care. Great having you all here today. And don't forget to share feedback in the survey that you'll see shortly here on your screen. Thank you, everyone.